Taking a posture analysis. The first thing we want to do when taking a posture analysis is you're going to have the patient take their shoes off. After taking the shoes off, have them close their eyes and have them march in place for a period of time until they're comfortable, and then you want them to stand as they normally would. Okay? There are a couple things that you want to look for too. Just because we're taking a postural analysis doesn't mean this is all we're doing. Everything is based on observation. You might have noticed that while they were marching in place with their eyes closed, they rotated subtly to the right or to the left, which could indicate a cerebellar or vestibular problem. You also might know that instead of the normal cross-crawl movement that they have when they're walking, they might exhibit the same or unilateral cross-crawl. In which case, these are something that you're going to cover with Dr. Kleinfeld and Dr. Bodner's class in FAP and what they mean. Once they're having, for the most part, once you have them stop, have them maintain their eyes closed for a period of time. It's a better way of actually assessing their posture. Once again, you may see things that may indicate a cerebellar type of a drift or a lateral sway, as learned with Dr. Michael Hall's class. One of the first things we take a look at posture is we look from the foundation or the base on up. One of the first things I want you to take a look at is let's take a look at the distance between their feet. Being in your early 20s, you really shouldn't have anything about 4 inches more so between the base of their feet. Anything wider than that usually indicates a problem with stability and or stance. So it's something you might key in on. The next thing we're taking to take a look at is let's take a look at the feet themselves. Standing in their bare feet, one of the things we want to find out is are arches normal? Do they have supination? Do they have pronation? A simple way if you want to look at pronation is I can take my finger, I can slip it underneath the arch of the foot. I should be able to at least get to the first digit comfortably if their arches are normal. Anything less than that would be suspect of having a foot that's a flat foot or pronated. We can always, since we're looking, in this case we'll look at the P to A view first. One of the things I want you to take a look at is the Achilles tendon. The inability to put your finger into the first knuckle or first digit up over here and an inward bowing of the Achilles tendon would suggest flat feet. If I see this, just as a recorder, I can make a mark as being either flat on the bottom here, or I can make an inward bow sign on the foot that I find an inward or an outward Achilles tendon. Another thing that you may want to take a look at is look at the foot positioning. Normally, foot should be slightly externally rotated about 10 to 15 degrees and be symmetric in presentation. Anything less than that would imply inward rotation of the femoral acetabular joint. Anything outside of that could be external rotation. We denote rotations by making a symbol such as this with an arrow on the end of it. So to that end, if I saw that the foot was externally rotated, I might want to place an arrow such as this way. The foot is externally rotated. Some of the other things that I look for, if their legs or their knees are exposed, we can take a look at their popliteal heights to see if the popliteal heights are at equal distances, equal heights. If not, we can demonstrate asymmetries. We can take a look at the knee position. Looking at the relative angle of the femur to the tibia, do you see what we call either a genu valga or a genu varus? If I saw a genu valga, I can make a notation roughly at the knee point by doing something such as this. As we come up to the pelvis, measure the iliac crest heights. If they're equal coming from behind, I leave the figure as is. What if I see a high right iliac crest? I can simply make a mark across the top. Some other things to look at with the pelvis that we have up over here is a pelvis in the midline. In essence, is there a butt crack over the midpoint between their 2 feet? If not, we might imply there's a degree of translation in the pelvis, such as this. This would either be a right or a left translation of the pelvis. If I do see a right or left translation of the pelvis, I can easily make a symbol, usually with a mark as an arrow, to the side that it's translated to. Another thing we can look for with the pelvis is any degree of pelvic rotations. Do I see pelvic rotated either to the right or to the left? If you do see a pelvic rotation, once again, we use our symbol for rotation, and I can draw pelvic right or left rotation. Now, to those that haven't had Dr. Wilborn's class in PT2, you will learn that we're going to perform in terms of mirror image exercises. So just something to think about, that You're starting, with posture analysis, you can begin to formulate your rehabilitation program as well. And if you're looking for active rehabilitation, we can look at what you learned with Dr. Wilborn's class and saying, how am I going to do mirror image exercises if I see these translations or rotations of the pelvis? The next thing I'm going to take a look at is the torso. Okay? If their spine is exposed, we can see if there's any lateral curvatures or scolioses of the spine. If they're clothing, the easiest way to do this is just take your hands and run it down the spine to see if we have any lateral curvatures. If you do see them, the simplest of mark is making the curvatures or drawing it in such as this. Either you're going to have a right or a left scoliosis, being a thoracic or a lumbar. Now here's another thing. While they're standing there, if you do happen to see scoliosis, the easiest thing to do is put in Adam's position to see if it's a structural or whether or not it's a functional one. And notations can be made accordingly. With the torso, once again, the thing I'll look for is just like the pelvis. Do I see any degrees of translations of the torso one side to the other? Do I see any tilts of the torso from one side to the other? Or do I see any torso rotation? Translations, the easiest thing to do, once again, is I can draw a line with an arrow on it. For rotations, as we did beforehand, I can make the same rotational signs or symbols. And if I see any degree of what we call the tilts or bendings, we can always just make a line out or a line in, depending which side it is tilted to. Next thing I'm going to look at within this is going to be the scapular position. Look at the shoulder heights. Are they level? Is one high, is one low? I can easily make marks to say that this person has a high left shoulder. I can take a look at scapular positionings, and do I see evidence of scapular retractions or absence of scapular protractions? If you can expose a spine that's relatively easier to see, because we can look at the position of the scapula relative to the midline of the spine. If not, let's say, for example, I have protraction here on the left because it's rotated anteriorly forward. Now, because I'm dealing with the left side scapula, I'm going to make a smaller rotation mark here. In essence, let's come to the arms are next. The hard thing always to differentiate is the inward rotation that you see. Is it caused by scapular protraction, or is it due to internal rotation of the glenohumeral joint? To that end, if I have internal rotation of the glenohumeral joint, the rotational mark that I'll place will be on the arm proper instead of it being over the scapula. Let's take a look at head positioning. Is the head in the midline? Are there any indications of degrees of tilt of the head? I can quickly draw marks to the right or to the left if I see a tilt. Is there any degrees of translation that I see in the head? If so, once again, I can make my simple arrow over to the side of translation. Are there any degrees of rotation of the head? And once again, if I see this, in essence, I can make the halo sign. In the lateral view, if you don't have a plumb bomb, it's difficult, or a sand machine where we can line everything, because basically the plumb line is to fall through the anterior aspect of the lateral malleolus, in essence the ankle. So the thing, if you're just going to visualize this, everything needs to be in line with the ankle. So let's look at some points. One of the first points we take a look at is the mid position of the knee. If we took the mid position of the knee neutral or normal, the mid position of the knee should be slightly forward of plumb. There should be a slight flexion of the knees. If the mid position of the knee is on plumb, the knees are relatively extended. To this end, I'm going to draw a single back. If we see excessive flexion of the knees, we can obviously bring the arrow forward. Next position we're going to look at is a greater trochanter. The greater trochanter should be directly over the lateral malleolus or the ankle. Once again, if it's forward of, we can say that there's a degree of translation, anterior translation, or posterior translation, what we see. Next thing I want to look at is the pelvis. Is the pelvis neutral? Well, to determine this, I want you to palpate the ASIS and the PSIS and take a look at the levels of your hand. In a neutral pelvis, those 2 points should be level. If the ASIS is lower than the PSIS, it implies that we have an anteriorly rotated or flexed pelvis. To that end, if this is what I see, I can just draw a mark up and over here. Next thing we're going to look at on the way up over here, we're going to take a look at the curvatures, the sagittal curvatures of the spine. the lordosis of the cervical spine, the kyphosis of the thoracic spine, the lordosis of the lumbar spine. I would recommend don't look square lateral with them, but instead come back to about 3/4 back over here, catty corner, to look at the spine. Sometimes the muscular bulk will give you false readings. Run your hand down the spine. Do I have a normal curvature, lumbar lordosis? I leave it as. If I have an excessive lordosis, I can make a notation such as this. If I see a flattening or a flexed lumbar spine, I can make a straight line. The same thing applies to the kyphosis that I have over here. If I have a flattening in region or the spine throughout, I can make a flatten in the area that I see this. As an aside, sometimes when you see flattening within the thoracic spine, when you're doing cardiovascular examinations, listen closely while doing auscultation. There's a high incidence of murmurs found with flattening in the middle thoracic spine. The same thing with the cervical spine. When I take a look at the torso itself, the entire torso, from the pelvis to the head, the mid-axillary line should fall on plumb. Sometimes you're going to see postures where the inferior aspect of it will be forward and the superior aspect will be back. In that case, I just draw my translation lines where I see them. Next point is the AC joint. The AC joint should be directly over the ankle or directly over plumb. If I have pronated scapula, you'll usually see them forward, so this is exactly what I'm going to do, is I'm just going to draw these forward. Take a look at their external auditory meatus, i.e. the ear hole. The external auditory meatus should be directly over the ankle. Don't be misled as saying it's directly over the shoulder, because if the shoulders have protraction of the scapula and the external auditory meatus is directly over the shoulder, in essence you have anterior or forward head carriage. If it's forward, which is a common postural finding, once again I make notation forward. Last but not least is take a look at the position. For the most part, I guess the easiest way to say it is take a look at their nose. For the most part, looking really at their zygoma, but looking at their nose. For the occiput to be neutral, the nose is, in other words, is what we call as confident. It's right on the water table. If I have positioning of the nose such that it's below the water table, I have a degree of occipital flexion. If I have it rotated posteriorly, in other words, you look cocky, that would be posterior rotation of the occiput. If I see these things, I make my rotations, which I will in a moment. Now, one of the common findings that you're going to see is you're going to see an anterior head translation or forward head carriage, with the occiput appearing to be neutral, in other words, on the water table. And this is where relative comes from. The only way that my nose can stay neutral with anterior cervical head carriage is by posteriorly rotating the occiput in order to maintain my vision on the horizon. In this is the case, what I'm going to do is I'm going to have arc over the top here, which indicates this individual has an anterior cervical translation or anterior head carriage with posterior rotation of the occiput. And these are some of the basic points. What are some of the things that you do these things? Well, if you go to Kendall and Schwartz in terms of the chapter, I believe it's chapter 7 with the motor system, barring any structural abnormalities, the muscles are the end organ expression of the central nervous system. And when you begin to look at these things, you might begin to see patterns, common patterns that you will learn to both assess in FAP, as well as Dr. Bob's PT2, and as well as Dr. Baggett's PT1 class. For example, if I have an anteriorly rotated pelvis, I have an increase in lumbar lordosis, I may have the signs and symptoms of a lower cross syndrome. So these are where you begin to ask yourself, of the muscles that govern the lumbar spine and the pelvis, which muscles would be facilitated? What muscles would be inhibited? So in this case, in an anterior rotation of the pelvis with an increased lumbar lordosis, I know that groups such as the erector spinae, iliopsoas, TFL, rectus femoris are going to be facilitated, pulling the body into this motion. And you're going to learn to assess those lengths in FAP. On the other hand, I know that the rectus femoris, the gluteus maximus, and the hamstring muscles are going to be inhibited. So when you do your rehabilitation program, you're most likely going to be stretching the short and tighten muscles. And while you get an increase in the length of those, you begin to increase the strength and endurance of the inhibited muscular groups. And these are some of the things that you'll look for on postural examination when putting them together.